Good afternoon. I'd like to thank the program committee for allowing me to present our work on the clinical utility of a self-reported swallowing outcome measure. These are my disclosures. Swallowing disorders or dysphagia are associated with morbidity and mortality across all disease types and may have profound social, emotional, and economic impact. Regardless of site of disease onset, 85% of PALS develop dysphagia at some point in the disease process. We've been talking earlier this morning in this previous presentation that the bulbar symptoms are perhaps one of the most distressing symptoms of ALS. As far as swallowing goes, it robs patients of their ability to enjoy meal times. The socialization of meal times is gone, and this can lead to isolation and reduced quality of life. The onset of bulbar symptoms are also associated with shorter life expectancy, and swallowing disorders may lead to malnutrition, compromised pulmonary status, pneumonia, and increased risk of death. Early identification is imperative so we can prevent these sequelae for as long as possible. In fact, the American Academy of Neurology recommends in their quality measures that patients be screened at each clinic for dysphagia, malnutrition, and weight loss. The Eating Assessment Tool, or EAT-10, is a commonly utilized screening tool and outcome measure that was developed to answer the need for a quickly administered, easily scored tool that assesses dysphagia symptom severity. It has 10 questions, basically they're statements, and the patients rate them from 0, which is no problem, to 4, which is considered a severe problem. The ratings are added up, and a patient receives an EAT-10 score of 0 to 40. The greater the number, the greater the dysphagia symptom severity. Normative data suggests that a score of 3 indicates that the patient already is abnormal and has some type of swallowing disorder present. The EAT-10 was validated on a general patient population. It was not validated on ALS patients. It's also been validated in multiple languages and is utilized worldwide. ALS clinics, including the clinics at Houston Methodist Hospital and Cedars-Sinai in Los Angeles, began using the EAT-10 as a method to screen patients for dysphagia and to assess for change from clinic to clinic. This is just an example of the EAT-10 form. You can see there's 10 statements, examples, because I don't think you can read that. Swallowing solids takes extra effort. Another question is, the pleasure of eating is affected by my swallowing. And again, the patients rate that from 0 to 4, but you could see the numbers 1, 2, and 3 are not, there's no descriptor for what that rating would be, so that's left up to patient interpretation. In 2015, Dr. Emily Plowman and colleagues published a study that looked at the ability for the EAT-10 to identify patients with ALS who had impaired airway protection during swallowing. So they had 70 patients that completed the EAT-10, and then they had a video fluoroscopic swallowing study. The results were grouped into safe swallowers and unsafe swallowers. The study found that patients that were safe swallowers had a mean EAT-10 of about 4. Penetrators, meaning material entered the airway but hit the vocal cords or stayed above it, and aspirators, which is more significantly dangerous, which is material went below the vocal cords, so down towards the lungs. And the aspirators had a mean of about 20. Further analysis in this study indicated that the EAT-10 was significant to identify aspirators with a cutoff score of 8. They also found that patients that scored themselves at 8 were about 3 times more likely to aspirate. The authors then go ahead and recommend that the EAT-10 be utilized routinely in ALS clinics in order to screen for dysphagia and make appropriate referrals for a comprehensive swallowing evaluation. So Dr. Plowman's study had us thinking about our EAT-10 data we were collecting in our clinics, and in discussions we recognized that a cutoff scale of 8 out of 40 was somewhat low, because we knew bulbar patients that would come in and they would score themselves in the 20s and 30s already, so already signifying that they had a significant swallowing disorder. But we also had observed that some patients were saying that their symptoms had improved, so they had an EAT-10 score that was higher on their first clinic visit, but then from clinic to clinic the score got better, so their symptom severity was reported as not so bad anymore. So we started thinking, what is the clinical utility of the E10 in ALS clinics? And we decided to pool our data together and try to answer these questions. Does the E10 accurately reflect progressive dysphagia in ALS? Should the E10 be used as a screening tool for safe swallowing indicators? And when do we stop using the E10 if a score of 8 out of 40 indicates somebody's already unsafe and probably aspirating? So combining our clinic data from a period of April 2014 to February 2016, we had a total of 216 ALS patients, 126 males and 90 females. Data analysis included comparison of the E10 with age of disease onset, site of onset, disease duration, forced vital capacity, ALSFRS, and the E10. We didn't find a significant difference between age of onset, site of onset, disease duration, ALSFRS, and BMI. But in our study, our group, the females we found had a significantly lower forced vital capacity when they had their first clinic visit. The mean was 72.3%. We also found that the females reported a higher E10 on their first clinic visit of about 8.6, so already indicating they were unsafe swallowers. Looking at the data by site of onset, we found no significant difference between site of onset and forced vital capacity, ALSFRS, and BMI. We did find in our group that, as expected probably, that the bulbar onset patients had a higher E10 score, and they averaged 15.3. Scatterplot correlation was completed with 512 individual groups of data, and we compared it with the commonly used measures of disease progression. So this is the scatterplot data for the ALSFRS and the forced vital capacity, and you can see there's no correlation. The dots are all over the place. On the right is the BMI data, and again, we found no correlation between BMI and E10 in our group. And then to look at the integrity of our data, we ran a scatterplot correlation on the ALSFRS and forced vital capacity. And we did find a correlation which supports other previously published studies on the ALSFRS and vital capacity. We then looked at longitudinal data for these areas, and we had 137 patients with 3 or more data points. So we looked at all that, and then we also grouped it by type of curve to determine what percentage showed an expected clinical decline, what patients showed variable change, so from clinic to clinic, how their numbers looked, and what patients might have shown a reverse trend, so somebody who looked like they were getting better. So this is the E10 longitudinal data, and you can see the lines go all over the place. They start high, they drop low, or some just keep climbing up. We found that 53% had the expected clinical decline, 18% showed variable change from clinic to clinic, and nearly 30% showed a reverse trend, so their E10 numbers got better as they went through clinics. It progressed over time. So we thought, well, this is interesting because it does support some of the observations we had made. And we kind of talked about why this might be happening. It is a self-report data, and it was, as was just mentioned, we also thought that our patients adapted to the dysphagia. They might be using swallowing strategies, perhaps they modified their diet, and it was no longer such a severe problem. Another consideration is that in the overall scheme of things, maybe swallowing wasn't a big deal anymore. Maybe they were more focused on respiratory issues or their lack of mobility. Looking at the BMI longitudinal data, we found 59% of our group had expected clinical decline. 15.5 showed variable change, but nearly a quarter showed a reverse trend, meaning their BMI improved over time. Now, the BMI is not a self-reported measure. It's calculated on a patient's height and weight. So some of the reasons we thought this may happen is in both of our clinics, we do a lot of really strong education initially on how important maintaining your weight is. In Houston, Dr. Appella is very well known for saying, you know, the heavier people do better. The fatter you are, the better you're going to do. Another possible reason is that the patients are no longer so mobile, and perhaps that can be attributed to some of their initial weight gain if they used to be more active. This is our forced vital capacity longitudinal data. We saw 67% had an expected decline, 18% variable, and 16% had a reverse decline so their forced vital capacity improved from clinic to clinic. Now, there's multiple reasons why this variability may be there. We don't have the data correlated in here as to what patients may have started non-invasive positive pressure ventilation, who is using a cough assist, who might have been using expiratory muscle strength training. In general, it's thought that these patients just developed a better pulmonary hygiene just from our education since the time they were first diagnosed. Finally, this is our ALSFRS longitudinal data. And we saw 90% had an expected clinical decline, only 7 a variable trend, and 3% had a reverse trend. So generally, this is the longitudinal data that you would expect with the disease. So in conclusion, I think this study highlights some of the difficulties in using self-report scales as a measurement of disease progression. We have shown in our group that nearly 50% of our ALS patients reported increased EAT-10 scores, or that their swallowing was essentially, the severity was no longer as bad in the context of actual disease progression and functional decline. The EAT-10 does not correlate with commonly utilized measures of disease progression, including the ALSFRS, forced vital capacity, or BMI. And that suggests the EAT-10 is not sensitive to the gradation of bulbar change that we see in our ALS patients. This was further supported by a paper that was published just about 2 weeks ago in the journal Dysphagia, and it was a paper that looked at the psychometrics of the EAT-10. And those authors found that the EAT-10 has poor internal consistency, and also that it did a poor job at taking patients with different levels of severity levels of swallowing difficulties and putting them into distinct groups. Finally, a weakness of the EAT-10, we think, is that there's a lack of item descriptors for the ratings of 1, 2, and 3, so that results in a lot of individual interpretation from the patients. In summary, based on the results of our study, our recommendations are that the EAT-10 should not be utilized as an outcome measure for swallowing in clinical studies because of patient variation in reporting their difficulties. And we also think that the EAT-10 would be best utilized as a swallowing screening. Scores of a 3 should prompt patient education about swallowing disorders, signs and symptoms of aspiration, and some safe swallowing strategies. EAT-10 scores of a 5 should trigger a comprehensive swallowing evaluation with a speech therapist, including instrumental assessment to determine if a patient does have penetration or aspiration, airway invasion. The clinical utility of the EAT-10, once a score of 10 is reached, is questionable. If a score of 8 indicates the patient's an unsafe swallower and likely an aspirator, it's not interpreted any differently once you reach a higher score. Finally, further analysis of the EAT-10 to determine if a subset of scores or perhaps a different scoring system would be more sensitive to ALS so that we could develop a more specific ALS swallowing outcome measure to be used in clinical studies. And then I'd like to thank my co-authors as well as the patients and families and staff of our respective clinics.
Wow.
I'm from Ohio, I talk fast.
You can repeat your entire thing. Now, are there any questions for Laurie?
Just one back there.
Hi, thank you. 2 questions. Opinion from you maybe on this. One, do you have an opinion on high fat content diet versus vitamin and minerals, in regards to feeding tube formulas? And secondly, do you have any idea or an opinion on the percentage of those folks with ALS that actually gain weight versus losing weight?
Okay, the first question. As far as the diet goes, I'm not a dietitian and not really educated so much on the specific diets. I know we do recommend a higher fat diet I know we do talk about that with our patients because I do consult with the dietitian, but we also are giving them vitamins. So I think at our clinic, we're doing a little bit of both. And the other question was, I'm still a little jet lagged.
Yeah, me too. Percentage of folks that actually gain weight. You know, you mentioned the physician there encouraging high-fat diet to keep the weight on.
And
Right.
we do a lot of education, and we do notice that. I know Peggy's here. I don't know if you have any comment on that. One of my
You had
co-authors.
the BMI data too.
The BMI data, showed that there was, a good quarter that had improvement.
Yeah, I'd say, and especially in our cohort, we did see that quite a few patients show an initial increase in BMI, and then obviously as the disease progresses, we do usually see a natural decline. I would say quite a few patients, ALS patients, will gain weight over a period of time, again, because of this education that we do on maintaining weight or increasing their weight if possible. So I think that's a natural trend that we would see, that the BMI would increase over the duration.
Yeah, some of them get very excited about if they have cardiac issues about no longer having to be on a very strict cardiac diet. So I don't know if that plays a role, or I know Dr. Appel pushes ice cream, so.
Okay, I'm going to do it. Any other
I know
questions?
you do.
All right, then join me in thanking Laurie.